I'm a pediatric hematologist specializing in bone marrow failure syndromes and pediatric MDS. And I just recently joined the Department of Hematology at St. Jude Children's Hospital. And today I just learned that Chip Chambers and me are fellow Tennesseans. So this is a picture taken at one of the first Diamond-Blackfan Anemia conferences. This was provided by Blanche Alta. The person sitting in the middle is Louis Diamond, one of the first doctors who described Diamond-Blackfan anemia. And the person sitting on the sofa from the left, the third one, that lady is Blanche Alta, who I admire for her knowledge in bone marrow failure syndromes, and I have the privilege to interact on difficult patients. So the work that I will be presenting is coming from the EuroDBA consortium, which is a consortium of investigators in Europe funded by the European Union. And now I would like to give you a brief introduction into Diamond-Blackfan anemia. And with that case, I want to exemplify that Diamond-Blackfan anemia is not only red cell aplasia, not only anemia, and it's not always easy to diagnose. So this is a girl that I took care of back in Freiburg in Germany. She was diagnosed at age of 3 months with red cell transfusion dependency, neutropenia, cerebral hypoplasia, and in the bone marrow we saw erythroid hypoplasia. She received steroids and responded well. At the age of 13 years, she was still steroid dependent and had neutropenia. At the age of 19 years, she did not require any therapy, had normal hemoglobin, however, elevated MCV, had neutropenia, ataxia, low B cells and NK cells. As shown on the right, we detected large microdeletion of chromosome 3q, which contains ribosomal protein gene RPL35A. This is one of the major ribosomal protein genes implicated in this disease. On top, you see abnormal polysomal profiling. I will show that later. We know that DBA is a disease of dysfunctional ribosomes, a ribosomopathy. Autosomal dominant ribosomal protein mutations are found in patients. Overall, about 75% of patients carry mutations or deletions in those ribosomal protein genes. Most patients are diagnosed in the first year of life. Almost all patients have elevated MCV, and the majority of patients, and this is interesting, the majority of patients have elevated erythrocytic ADA. Erythrocytic ADA is ADA1 enzyme in the red blood cells. We don't understand why, and many patients have elevated fetal hemoglobin. Clinically, congenital malformations are found in about 60% of patients. Patients respond to steroids with long-term responses. And now, since a few years, we know that DBA is also a cancer predisposition syndrome. Recently, this year, it has been published that DBA can predispose to colorectal cancer. Now, those are the 3 standard therapeutic approaches in DBA. In the first year of life, patients are transfused. From the second year of life, we undertake a steroid trial. About 1/3 of patients remain long-term steroid responsive. 1/3 of patients go into transfusion dependency. About 20% of patients attain therapy independence, and only 13% of patients are transplanted. The problem lies in the early identification of patients who would benefit from transplant, who develop complications later on. Now, coming back to the ADA2 deficiency, this was the patient that triggered the whole study. So this was a 7-year-old girl from Germany who was previously healthy, who presented with recurrent fever, erythema nodosum. She had low hemoglobin of 4.8, normal MCV, normal fetal hemoglobin, and erythrocytic ADA. She had hypogamma and low NK cells, low B cells. The bone marrow showed erythroid hypoplasia, and interestingly, she was steroid responsive for nearly 2 years, but then went into transfusion dependency. She was transplanted at the age of 12 years from a much unrelated donor with excellent outcome. We identified biallelic CRCR1 gene aberration. One was a stop gain mutation, the other was exon 9 deletion, and the ADA2 activity in plasma was basically 0. Now, this patient triggered the analysis of a larger cohort of patients with Diamond-Blackfan anemia diagnosed in Germany over a period of about 20 years. We asked the question, what is the prevalence of patients with ADA2 deficiency in that cohort? So overall, 242 patients had material available for analysis. We identified mutations or deletions in those ribosomal protein genes in 57% and 10% of patients respectively, and 1/3 of patients had unknown genetic diagnosis, so those patients were subjected for the analysis, and overall 5 out of 68 of the patients, so 7%, have compound heterozygous mutations of CRCR1 gene. One of those 68 patients had heterozygous missense mutation, but that patient had been excluded from further analysis because the ADA2 activity was normal. And all the double mutated patients had very low ADA2 levels. Additionally, we found 7 patients with ADA2 deficiency and pure red cell aplasia in Euro-DBA countries, France, Italy, Turkey, and Israel. And I would like to show you the phenotype of the first 7 patients with ADA2 deficiency that we found presenting with red cell aplasia. So most of the patients are diagnosed very early in infancy, but however, there are some outliers, 7 years old and 14 years old. The majority of patients have no malformations. Red cell transfusion dependent are all patients. MCV is elevated in about half of them. ADA and fetal hemoglobin is normal in all of them. B cells are decreased as well as immunoglobulins. And some of the patients respond to steroids. However, this is transient. 4 of those patients had been transplanted with excellent outcome. And at last follow-up, one of those patients who had not been transplanted died at the age of 28 years from sepsis. In the other cohorts from Italy and Israel, in the 5 additional patients, all patients were transfusion dependent, had hypogamma, and 1 also died from sepsis. So similar phenotype. Now, I would like to show this to you to point out that we believe there might be a first genotype-phenotype correlation. 10 out of the 12 patients we identified with red cell aplasia had at least 1 frameshift or stop mutation, which is an enrichment compared to what has been previously published in the cohorts that many of you had published previously. Those nonsense mutations that we find, those frameshift mutations, as shown here, they lead to RNA degradation. This is RT-PCR from 2 patients with those truncating mutations, CSCR1 exon 2. You see that the RNA is degraded. And finally, we also wanted to look at the ribosomal assembly in our patients. We wanted to answer the question if the ribosomes are affected, and they are not. So on top, you see a patient with ribosomal protein S19 deficiency and Diamond-Blackfan anemia. In that patient, the small subunit of the ribosome, indicated by the arrow, is depressed. Those are 2 healthy controls. And on the bottom, you see 3 patients with ADA2 deficiency, and the ribosome profiles look normal. Now, we also looked at the suppression of the red blood cell production in the morpholino when we suppressed the CRCR1 gene. And we used the morpholino that was previously published in one of the first descriptions of ADA2 deficiency. And we looked at the amount of hemoglobin-producing cells. And interestingly, the higher the suppression of the CRCR1 is, the more severe phenotypes of red cell depression you see. So this on the bottom, you see a severe phenotype with basically missing red blood cell producing cells. And this is the last slide here. We wanted to answer the question if the defect might be intrinsic. So what we did was we cultured primary CD34 cells from patients with ADA2 deficiency in red blood cell differentiating conditions. And in the 2 patients, you see that after a period of 12 to 14 days, there is a hypoproliferation of the red cell lineage from patient CD34 cells. Similarly, when we cultured the LCL lines, lymphoblastoid cell lines derived from B cells of those patients, we see a reduced growth of patients' cells compared to the controls. So I would like to summarize. Overall, 7% of patients enrolled in the German Diamond-Blackfan anemia registry with unknown genetics carry biallelic CSCR1 mutations and have no signs of vasculopathy. 12 patients with ADA2 red cell aplasia overall had been identified in our Euro-DBA cohorts. All patients have red cell aplasia plus hypogamma and no vasculitis. And there is a transient response to steroids, but however, this is only transient, and after all, we probably need to transplant all those patients. The transplant results were excellent in our group, and all the patients had been transplanted from much unrelated donors. We believe that there is a role of null mutations in probably inducing that red cell phenotype. We see an enrichment of null mutations in our cohort. So I would like to emphasize my gratitude to Mike Hershfield for performing the ADA2 activity assays for us. Thank you very much.